Afternoon. It's good to see all of you. I'm Pam Jeffries, Dean of Vanderbilt University School of Nursing, and it's my pleasure to welcome you to hear Peter Bierhaus present Educators, Leaders, and Nurses Resetting Relationships. Dr. Bierhaus is the leading authority on the economics of the nursing workforce, provider workforce projections, and the state of the current nursing workforce, and how nurse and physician shortages impact our country. As many of you know, Dr. Bierhaus was Senior Associate Dean for Research and Professor of Nursing and of Health Policy here from 2000 to 2015, and worked with many School of Nursing and School of Medicine and VUMC colleagues on a variety of research studies. Currently, he directs the Center for Interdisciplinary Health Workforce Studies at Montana State University College of Nursing, where he is also Professor of Nursing. Dr. Bierhaus will be joined by two of our alumni from the DMP class of 2013, Linda Hewlett and Lydia Rotunda, for Q&A. Dr. Hewlett is the Chief Nursing Officer and Senior Vice President of Patient Care Services at Regional One Health in Memphis, where she oversees strategic operational, clinical, and financial leadership for all inpatient care units. Dr. Rotunda is Associate Dean for Education and Student Affairs and an Associate Professor of Clinical Nursing at the University of Rochester School of Nursing. She provides strategic leadership for the school's undergraduate, master's, and doctoral programs, and is the director of its Doctor of Nursing Practice program. We are very grateful that both could join us this afternoon. And now, please join me in welcoming Dr. Peter Bierhaus. Hey.
Let's see. I think I'm there. Do you all see my my screen? Is it working?
Yes.
I think so. Okay, good, great. Thank you. Well, thank you, Dean Jeffries, for having me here. It's great to be home again at Vanderbilt University School of Nursing. And thank you to Sarah and to Betsy for all their help today. It's been a good day. I've had a chance to speak with the faculty this morning, and we're all getting kind of taking our masks off and talking to each other and being with each other. So it's a good conversation. And then I was able to give a presentation a little bit later in the day too. So this is the presentation that I've been thinking a lot about because I think it is a hugely important, activity that we can all do, which is really resetting our relationships. And I'm just going to get things going, and I'm not sure how to advance the slide. I'm used to a different kind of a computer, so let's see if I can get that to move. Sarah, if you're available, can you come back in and help me move the slides forward? I'm not seeing how to do that at the time. What am I missing? It's not advancing. Oh, okay, there we go. All right, thank you. All right, so I thought what I would do is try to talk about resetting our relationships and why should we be doing that, and then who should be resetting relationships, and then end with really a very focused, look at chief nurse executive officers and deans, and by extension to the CNO and their leadership staff, and the dean, meaning an extension to their faculty, and really propose something that came out of a prior conversation with Lydia and Linda. And I forgot who said it, but we all agreed that the new normal in these relationships should be joined at the hip. That would be our new normal. So I'll try to end up there. Let me then move forward and just to disclose my relationships with funders, some of the current funders and some very recent past, and then some of my board and committee relationships that are in the recent past or ongoing. None of these, I believe, bias any of my remarks. And I'd just like to acknowledge my teammates who are too many to identify, but these are my colleagues in my interdisciplinary research teams. So why reset relationships? We'll start there. And again, my focus is primarily around educators and leaders, but as we'll see, that'll broaden out as well. I think that COVID has just been this impact that has affected our whole healthcare delivery system, our public health system, nurses, and much more broad, the social and the economic and the political fabric of our country has really been in for quite a disruption that none of us saw. And it feels as if we're sort of, moving out of an acute phase and maybe into a more positive future. But we also know that the pandemic, if anything, it is predictably unpredictable. We just don't seem to be able to predict it. And I worry that in some sense, because it's unpredictable, we don't know what will happen. It's as if some folks are saying, well, we'll just wait and see what happens. And I think that this is the time to actually reset our relationships so that together we can strategically plan on how we want to act to shape our future versus wait for it to happen. Let's act and shape our future. And there's a lot of distractions going on in society, but in nursing and in our field. And you just have to go to any social media outpost and you'll see all kinds of different issues and concerns and passions that people believe in. Some of them are pretty crazy and some of them make a lot of sense, but there's a lot of distractions out there. I'd like to level set a little bit though, and make sure we're all sort of seeing the same picture. This is some data that we are collecting in a grant that my economics team has. And up on the left, you see February of 2020, and all the way to the right, December of February of 2022. And if you go to the left of the screen here, and you can see that immediate drop in late March and April when the COVID pandemic began. The blue line at the bottom are offices of physicians. They dropped the most, over 11%, and it was just an immediate drop, followed by the outpatient care centers. Didn't drop quite as much, around 8%. The sort of pale blue line are home health care. They also dropped quickly. The grayish line are hospitals. They did not drop as fast or as steeply as the other sectors. Now, as you move to sort of the middle of the slide, you can see that in October of 2020, the first sector of healthcare, and by the way, this is total employment. So not just nurses, but everybody in these sectors of healthcare delivery. So total employment. And in October of 2020, outpatient care centers employment got back to its pre-pandemic level and then exceeded that and has remained so over the past year or so. And it was in October of 2021 where offices of physicians finally, that employment there, finally reached pre-pandemic levels and now has picked up. But total employment for hospitals is still down about 2.5%, that gray line that's never gotten back up to its pre-pandemic level. Home health care has been down about 4 to almost 5% for much of the pandemic, but is showing some signs of improvement lately. Now, the yellow line are our nursing facilities. They've never recovered. They've never rebounded. They've never had a return back to pre-pandemic. It's down about 15% below a story that we're very familiar with. So that's the total employment picture of where we are standing in healthcare today. Now, why are we resetting relationships? Why do I think this is important? And frankly, from all the years that I have been in academics and in years where I was in administration and leadership, I don't think I've ever felt there was a time when it was so important to have strong relationships. And given this enormous shock of COVID this is where I think it is that the need to reset these relationships, because we're still not out of all the woods, as that prior picture just showed. And that we have some other issues that I want to indicate about why we should. And these are projections that you see on the slide of the future supply of registered nurses in the US. The blue solid line are actual numbers of RNs in the country. And in the yellow or oranges sort of dots, those are our forecasts. Now, the model we built and developed in the late 90s, and we used it to periodically update the future supply of nurses. We've applied it to physicians and others. We have a lot of confidence in the model. And in 2017, we published the last public version of our forecasts. And 2.5 months ago, we updated the model using data all the way through 2019. So right before the pandemic began, we forecast, and these are our projections. And what you see is a continuing projection that shows we'll grow the workforce by 1 million. Now, with that, that's a pretty positive forecast, because that means we're going to actually replace the 640,000 RNs born in the baby boom generation that will retire over this decade. We're going to replace them and still add another 1 million RNs. So it's a very positive forecast, but it relies on continued entry into nursing education programs, graduates, and into the workforce. And there are some concerns on this. And one of the factors that I want to stress in this conversation today is we've got to preserve those forecasts. This is important to grow our workforce, and I'm concerned that the messaging that is out there on the formal media, television, radio, and in social networking media, you name it, has grown from being positive in 2020 about nurses to now we often see nurses talking poorly about nursing as a profession and as a career, and poorly about the hospital that they work in. It's too much. It's too negative. It is emphasizing lots of unprecedented shortages, there are negative effects, a lot of blame. It's not a positive portrayal. And I feel that we need to counterbalance these negative portrayals with positive images of nurses. If we don't, we could risk entry into the profession. And that's a risk that will be immediately borne by our chief nurse or by our deans, who this is their business, is to educate. Now, I want to take you back to the 90s. Some of you will remember this. And to make this point, that how important it is to get our messaging right. Back then in the 90s, we were using market power to slow down cost growth and total spending in healthcare. And to do that, policy was, well, let's build this around HMOs, and we'll get hospitals to compete for contracts with HMOs to get their patients. And that meant that hospitals had to quickly lower their costs to be price competitive to win these contracts. To do that, they looked, of course, at their costs. And hospitals, as a labor-intensive organization, meant that they would have to look at labor, nurses as the largest component of labor, and also among the highest paid of professions in hospitals, obviously meant that nursing would be looked at to bring these costs down to get these contracts with HMOs. And it turns out that hospitals did, in fact, slow the growth of employment of RNs from a usual 2 to 3% annual increase in the number of RNs they were employing. They slowed it down to about 1%. But also many organizations reduced the number of support staff for RNs. What this led is a lot of protests around the country in major cities, and it was particularly strong in Washington. Very visible, very unhappy nurses making lots of very negative and disparaging comments about healthcare, about hospitals, about their profession. And what was the unintended consequence of this is that we saw a subsequent decreased interest in becoming a nurse, less enrollments, less graduations, and ultimately a shortage of nurses developed. This is a slide that shows the interest in careers as told by college freshmen across the country. UCLA does these freshman surveys, and you can see that the percent of freshmen indicating an interest in nursing dropped pretty remarkably after 1993, fell down all these years straight through 2000. So we see this decreased interest in nursing, and enrollments fell, and these are graduations in 1995 to 2000. In 1995, we were graduating about 97,000 nurses, RNs each year. By 1999, that number had dropped to 67,000 graduates, 30,000 fewer in just a few short years. And if you look carefully, you'll see that way out in 2005, we're still way behind the number of nurses graduating compared to 1995. So these were substantial declines in the numbers of nurses available to work in the workforce. And not surprisingly, beginning in 1998, we had the development of what later became the last large national shortage of registered nurses in the country. So when I think of shortages, this would be like a Cat 4. There's a Cat 5 out there with even larger numbers of RNs, but we haven't seen them for many, many decades. But this is a big one. This is a Cat 4, lots of hospitals affected. Organizations had to shut down some of their units, reduce hours, access to care was affected, quality of care was affected. And so what I'm concerned about is we could sort of repeat that experience given the messaging that we're having now. Now, something that I think that many of you know, but we're all alums here, something you may have forgotten is that the Johnson & Johnson campaign for nursing's future, which was launched in 2002, was born at Vanderbilt University School of Nursing by conversations that originated literally 10 feet from where I'm sitting. And that campaign developed, and we all watched it grow and spread. And it had an amazing impact because it provided these very positive images of nursing. And you can remember the Olympics, the Super Bowls, the television programs. You couldn't miss seeing these images of nursing. And we had the promise of nursing celebrations. Remember, we would all dress up and go downtown. Some of you that were in cities that had these celebrations, and we sat with our CNOs, we sat with our physician leaders and nurses, and we had an evening of enjoyment where we watched presentations about the importance and the vitality of nursing. It was a wonderful gathering. Many dollars were raised to support faculty and students, and every high school in the country, a guidance counselor there received a brochure about nursing. So this was a massive campaign, and you can see here on this slide, it was launched in 2002. And to the left of the arrow is that declines that I was talking about, and look at to the right of the arrow, we have this remarkable increasing number of people becoming nurses in our workforce. So this is an important part of our history. We were lucky we had J&J to help us as we saw those declines, but we don't necessarily have them or some other social force that could help reverse the trends in nursing if they turn negative and we get into trouble, if we repeat the 90s. I think this is a shared responsibility of our educators, of our leaders, of nurses, across the board. We have to be careful. I'm not saying sweep negatives under the floor or under the rug. That's not what I'm saying. We need to better balance, though, what is all essentially negative with more positive images. We need this workforce to grow in the future. Now, some of you may be saying, but didn't I just see yesterday that enrollments are increasing? And that is what was announced by the AACN, that there was an enrollment increase in 2021. So I am glad about that. But my guard is not down, because while that is in 2021, we don't know what that will be in the future. But what we do know is something that our team just discovered about 10 days ago, and it will be now published in a blog in Health Affairs on April 13. But that'll be next week. A blog will be coming out that'll describe this. But what I want you to see is in the blue, the total number of RNs over time. And it goes way back to 1982. And there's this nice growth all the way up to about 2020. And then you see that sharp drop. That drops about 115,000 RNs that have left the workforce. And you don't see anything like that in the prior decades that comes anywhere close to this. This just jumped out at the team, and we were quite concerned about that. We immediately said, where's it coming from? And we expected that this would be maybe accelerated retirement. But the figure here shows in yellow that that's not the case. We didn't see, at least on a national level, a big surge out. Where we see that decline is among younger nurses, 35 to 49 and under 35. So this is a significant drop. And when we compare to what we had forecast with our model, we had predicted that between 2019 and 2021, the workforce would grow by 4.4%, but now we're seeing it's actually decreased by 1.8%. So this is an exit challenge that now affects the CNOs. The entry challenge I mentioned a minute ago, which affects the deans, we need to sustain that workforce, because now we've got to grow it even more given this exit. Now the question is are these permanent drop out of the workforce, or are they temporary? And we have lots of ideas about why nurses in these age groups may have been temporarily leaving the workforce, but we don't know that. We have surveys now in the field to try to get the information on that to find out if these are permanent or transit withdrawals. Another exit challenge that is facing our but mainly our CNOs, is the baby boom generation, the remaining 640-some thousand nurses who will retire during the decade. Our estimates show around 70,000 are leaving each year. With that is this loss of clinical leadership and organization, skills, mentorship, being able to just work the system and know how to get things done. And we know that in some organizations, prior to the pandemic, these withdrawals from these very experienced nurses were already creating shortages in some of the ICUs, the EDs, the critical care units that were impacted by COVID. So we've got a challenge on this retirement. And I wanted to point out that as we are looking at the loss of millions of years of nursing experience leaving the workforce over this decade, where we expect much of the challenge will be in nursing homes, rehabs, home health, occupation, and sort of in the non-acute care areas. But we'll also see retirements among deans and senior faculty. We'll see retirements among CNO leaders and of their leaders underneath them. So we've got a retirement issue that will jointly affect both deans and CNOs. Another exit challenge is this growth and interest in becoming a nurse practitioner. It's been a phenomenal growth. We don't have time to go through all of it, but a lot of growth of nurse practitioners over this past decade, particularly since 2013-ish or so. What we have calculated and published in a paper was that the interest in the number of people who left their workforce position to become a nurse practitioner resulted in a substantial decrease of about 80,000 RNs from the labor markets across the country in the years 2010 to 2016. Now, we didn't update the analysis, but we know that probably continued to happen from 2017 prior to the pandemic. And so add this with the retirement, and you had a number of organizations who were vulnerable, who were weakened by, in terms of the quality of staffing and the numbers of staffing when the pandemic began. So this is a challenge, and you can see the growth of the nurse practitioner employment from 90,000 to about 241,000 in a 10-year period. Very, very strong growth. And most of this our NPs are employed by physicians, then hospitals, and in all these other settings. And it's a large number of settings where NPs are employed. We all know that. We should be proud of it. Many of us graduated from the USN to be in those settings, and you're there. It's impressive. We have a large workforce, and when we think about the future, we published a study a few years ago in the New England Journal of Medicine. We compared it, the growth of NPs to physicians and physician associates, and you can see the growth now is strong. We will more than double from where we're at today to in 10 years or in 9 years by 2030, we'll have almost 400,000 NPs, much stronger rate of growth than that of physicians or others. So we're going to have this workforce continuing in large numbers. How can we leverage the interest in becoming a nurse practitioner and yet incentivize, can't get my word out, RNs to remain at the bedside? This is an area where our CNOs and our deans really need to sort of figure out and put their heads together, a lot of heads together, to see how we can take this force of the NP and manage it in one way or another to help us retain nurses inside the bedside. And I think there's some new models of care that could be nurse-led that could get us there, but it's a tough one. Now, beyond entry and exit concerns, there's two other areas I think that that will need to have CNOs and deans and faculties binding together. And that is, are we preparing the types of nurses and APRNs needed by employers and by society? And how do we address social determinants of health and achieve health equity? And again, these are tough struggles that individually left to them, are not going to get done. But if we partner and we grow and we work together, I think we'll have a better chance of making some material improvements going forward. But the first question, are we producing the types of nurses that we need, both APRNs and RNs? You can see from this data, there's a lot of growing population demand that comes around from aging of our population and the large use of medical care and healthcare by the aging population, the mental and behavioral health, a crisis already before pandemic is expected to be even larger in the years ahead. Access to primary care has worsened, not gotten better, and high maternal mortality is still with us and is starting to peak back up throughout the pandemic. And when you look on the right, the supply of our nursing workforce, we're very underpowered in all these areas: gerontology, mental and behavioral health. Thank God we have so many NPs in primary care, but it's still not enough to get the job done. And we're not getting the certified nurse midwives production that I think we need. So there's a big gap that is going to affect our employers, and it will in fact affect what our deans decide with faculty, how we're going to address these gaps. And then, of course, the gaps that that we need to address in terms of social determinants of health. And I think there's a lot of interesting, projects and experiments going on in organizations that are nurse-led, trying to address these social determinants of health. These are rich opportunities for faculty and students to do research on, to document the outcomes, the costs, the benefits of these. But we need to work closely together, because this is a long-term challenge that will require all of nursing to put their heads together on. So, and I'll end this piece by saying, in a study survey that was done by the federal government, the 2018 National Sample Survey of Registered Nurses, the question was asked of nurse practitioners, what could have helped you do your job better if you had received training in the following? And there was a long list of activities, but the areas that our NPs said that could have helped them do their job better is that they had received more training in social determinants of health, mental health, working in underserved communities, and providing care for medically complex and specialty needs patients. That's what our NPs are telling us the educators need to help fix. And we know our organizations will need nurses with this type of education to make serious dents. Now, I'm starting to run a little long, so I'm just going to quickly say who should reset relationships, and then we'll end up in 4 or 5 minutes from now. Okay, so it's all of these groups. And I think hospitals and nurses at the right time, once we feel we're getting our breath back and our feet are on the ground and we can look forward, let's sit down and talk with each other and understand what happened to us. What were the positives? What do we want to take forward? How did we grow clinically? How did we grow as leaders? What were the things that didn't work? Where we just didn't get it right? What did we learn about our culture that we want to get rid of or improve? And as we do this, listen hard to each other, why we made such decisions. And if we need to even apologize for it to each other, that's okay. But we need to bind and come back together. Hospitals and nursing students, nursing students have had a tough time. What worked for them? What really excited them? What were the challenges that make them so excited about nursing? Let's understand those. Let's build them, understand what new skills they learned and what examples of leadership that they witnessed and people they want to become because they were in your organization, and re-invite them to be back in our workforce once they graduate, back in your organization. Let them know how important they are. Let them know how you want to work with them to build a very, very positive future. And our relationships with the public and the community. And I don't mean to be self-congratulatory or bragging or anything like that, but I think the public would appreciate knowing things about what happened with nurses. They've seen the stories, but what about the positive stories? What about knowing the number of people who were saved, that nurses contributed, that are alive today, the number of vaccinations, the number of shots and other activities that nurses were instrumental. And maybe this could be a television show or a documentary or something, but the public, I think, would appreciate knowing what happened and how students were affected and need to be supported. And that whatever we do going forward, we are telling the public that whatever it is, we will make sure the outcome will be an environment that makes sure that you are safe in our organizations, we protect you, and our quality of care is not sacrificed, but constantly improving, and then add in whatever else you want to do. But reconnect with your communities. I'm going to skip over the economic relationships that need to be reset, but essentially I would say we need to embrace value-based payment. It allows us to align the incentives to improve outcomes and to lower costs. With nursing, which we want to improve our outcomes, we need to get better at lowering costs, because in the future, hospitals will be paid more, increasingly more, on do they improve outcomes and lower costs? If you do, you get more reimbursement. If you don't, you get less. Nurses should understand that, work to do this, and hospitals, I think, can help educate our faculty to understand the components of value, which is really outcomes and costs. How do we improve those outcomes? How do we lower those costs? And bottom line, I would like to propose that we take the quality improvement framework that we have done so well and apply that to how do we improve value-informed nursing practice. I think that could be something that has great payoffs for the profession and could, again, involve both our leaders and our nursing educators. I'm just going to finish up with one or two more slides here, which is this relationship of involving deans and CNOs. And again, I like this idea of becoming joined at the hip as being the new normal. And I think all of us want to see leaders. We want to see examples of leadership. And this, to me, when you have CNOs and deans working together, and I saw this 2 weeks ago at Emory when I was there, I saw it last week at Creighton University, where the leadership is together, listening, working together, and having a plan that they have both worked on jointly to act on the future with goals that are meaningful and using facts and data and adjusting this as we go forward. I think this is a strategic relationship. The dean needs to know very directly, what does the CNO need? What are the important issues that have to be addressed and addressed successfully over the next year? And the same for the CNO needs to know what the dean is most concerned about and needs to accomplish. What can be done to mutually support each other's accomplishments of their respective needs? Some may overlap, some may not, but we need to know which ones do and what specific activities can be done to support that. So we're no more nice, monthly conversations or breakfasts or that. This is a strategic relationship where both interests are much more connected together. And I feel that I don't have it, I don't know this, but what are those necessary ingredients to become joined at the hip? And I think that's a good question to ask of each other. What is it going to take to form this relationship? And if we can do that, then extend that to the body of faculty and with your leadership and your organizations, so that they in turn meet together routinely, understanding the various positions of each other, figuring out how they can work better together. And that in itself is a huge bit of leadership that I think has been missing, and we need to address that. So I'm going to stop there and say thank you. And I'll turn it over to Linda and Lydia, who are going to jump in here. And I'm going to try to do the stop share and see if that works. Okay. All right.
Well, thank you, Peter. I am Linda Hewlett, and with me is Lydia Rotunda. We'd like to take a deeper dive into the relationship between the schools of nursing and employers and the barriers that exist. And we'll also field questions in our Q&A. So if you have questions, and we definitely need you guys to put some questions in the Q&A. I know that Peter's conversation is very stimulating. His information is very timely because we're in dire straits here. As a CNO, I can personally say that we have struggled for the last 2 years with this great resignation. And now as we pivot toward the great renewal, it's an exciting time for us. I feel that it is, and all of his discussion, his presentation is very timely. And so I will start out with a question, but like I said, we encourage you to put questions in the Q&A so that we can ask the expert, Peter, to help us with this situation that we find ourselves faced with. So I know that Vanderbilt has a longstanding history of a successful partnership between the School of Nursing, because I graduated from there. I worked at the medical center, but what is the secret sauce or the ingredients for a successful partnership? Because not everyone has that secret sauce. We don't have an avenue for acquisition of nurses through a School of Nursing and a academic medical center. So what are the ingredients for being able to forge or establish these new relationships, Peter?
Oh, I was hoping you would ask somebody else. You know, I would say probably the components of any really good, strong relationship in life, which is the ability to be totally honest with each other when things are not going so good and maybe are painful, but to put those out there. A trusting relationship. And that sometimes requires the activities that build up trust in case they're not there currently, but a dedication to trust each other and to be honest with each other and to honestly hear what the other individual is saying to you about what are their needs versus their wants, and to say, I can help you here, but when you do this, it hurts me over here. So there'll be tension in some of this relationship that I think you'll have to acknowledge and work through in a very, honest and trusting way. I also think that the relationship needs time. You need to carve out time and say, this is a priority in my life. And I think it's so easy to just get swept away in your other worlds. But before you know it, there'll be missed opportunities if you don't have those close relationships. And I think, I'm going to say, Linda, it was you, but it might have been Lydia, who said a few weeks ago, we've got to become joined at the hip. That's got to be our new normal. I wrote that down. I loved it. I put it in the presentation. And so I'm not sure, I think it was you, Linda, but I think that's the goal. We are going to be joined at the hip. And so those are my reactions: time, trust, honesty, understanding what's very important to each other, and dedicating yourself to helping your partner achieve that.
Absolutely. I love that. Dedicating yourself to develop this partnership to achieve success. And I believe that to be true. And so, establishing that conversation earlier versus later, it will only benefit, I do believe. And from what you said in your presentation, I find that to be true. So we do thank you for that. And we would like to take a question that is in the Q&A.
Linda, could I just add something to that?
Sure.
Because I think from my perspective, you identified, Peter, those ingredients. I think from an academic perspective, I look at the terms that come to mind for me are relevance, responsiveness, and really interdependence, which is essentially saying join at the hip. So it's like relationships. And what I mean by, there's so many examples, and maybe some of this will come out in terms of ways in which you take that concept and demonstrate it in practice. But I think you have to understand the role that each of you plays in the larger whole. And you have to think of yourself in that way. So the relevance has to be mutually relevant. We can't just be educating nurses in a way that this is the way we've always done it, or we're following the sick model of care, or, we have to have inputs that make practice broadly very relevant to what we do and informs what we do. And then as a result, the output of that is what is the product? One of the things that I think about from a responsibility as an academic person, from an academic perspective, is preparation. You looked at those exits and entry. So entry, are we putting out messages around nursing that demonstrates the full trajectory of what nursing looks like, right? What does it mean to be a nurse? People have a very narrow model. And I do think that COVID has not expanded that model. I think people think of nurses in COVID in still a very traditional way. And we know the ways in which we've lived and experienced the ways in which nurses have a very rich opportunity to contribute in all levels and in many ways. So I think that's one element. The other thing is then to develop educational programs that really equip them to be able to go out and be informaticists or be, different specialties. Or and then the other thing I'll just say is that we need to think about, are we graduating students with skills? We talked about the whole shift in movement to competency-based education. That might help reduce the exit. Are they well equipped to handle the transition? Do they have the delegation abilities that they need? One of the things that I think is really important is we talk about nurses as knowledge workers in a digital age. Are we equipping them to have the digital literacy skills, to understand their role as a knowledge worker? Do they have systems thinking? Do they have understanding systems and systems thinking, both in terms of our education process, how we educate them, as well as a product, so that when they get into these environments, which are really like battlefields, they have a broader tool belt to recruit these really important tools. So I think very responsibly around that, to produce better graduates at all levels, nurse practitioner, undergraduate, for our practice partners. And so that's just some of my thinking around responding to your slides, which I think are really powerful by the numbers.
Yeah, go ahead.
No, go ahead.
No, I like that, Linda, because I think you're painting a vision of a very different workforce that we were being educated and used in our organizations prior to COVID. And why would we want to go back? So we are going to have to join at the hip to figure out what can we do in the future, what's feasible, and how it aligns. And I think that if the faculty could be meeting with the leadership of the organizations and vice versa on a routine basis, we would get really smart about, this is where they're going in the organization. This is what we can do to improve and really use ourselves. And it grows our intellect and it grows our pride. And so I don't know how else we can do it if we're not having these close resetting of our relationships to really value this.
Yes, and I think that's very critical to building our pipeline, is to, really sit down once a month, because it changes so often that we need to have these ongoing conversations to, identify our opportunities and what are our barriers to this education or academic side and with the inpatient side. So we just kind of need to have those critical conversations and just be honest with each other to develop that trust so that we can have a win-win. So you're absolutely right, Lydia.
Linda, this is a question for you. Are you finding that the younger nurses in your facility are the ones who are leaving, as the national data shows us? And what are the driving factors?
Well, I would say yes, we're no different. We're in that Me Too, yes, as the rest of the country. What the CNOs around the country rather are facing is a lot of the young nurses are leaving, the older nurses are retiring, and those in between are staying secure or staying put because of other reasons. They're stable, they want to stay local, that kind of thing. But one of the driving factors here is the incentives that are constantly being offered and changing. We are, we used to compete with the region and the nation, but now we're competing with our local market. And it's almost a battle trying to stay current as to what everyone else is offering. So you can beat them, with your incentive package. And so that's a constant battle. It has been a battle for the longest. And so it's those types of things. And because we have dealt with this pandemic for the last 2 years or so, it has caused us to shift our priorities. And so it's almost a constant day-to-day survival until we are, we forget that, yes, they do need professional acumen. They do want professional growth. So what are we putting in place for that? So as we look forward to this great renewal, those are some of the things me and my leadership are looking into, because, there'll never be enough money, and we cannot exhaust our resources, and we have to be fiscally responsible. So we made a choice that, we're going to rather partner with our School of Nursing here, and we were going to build a very pristine pipeline so that we can acquire nurses, so that, and just build it, because a lot of the young nurses, they are not leaving just because of money. They leave because there is no growth. So as Peter alluded to earlier, the negative images of what, they have this image of what nursing should be, they get inside the organization and they're really taken aback, and it is not what they envision. So I think the key to some of this is to construct a survey and ask them. They're the ones who can tell you. And so why would you want to leave? What will keep you here? These kinds of things, because a lot of times I find that these nurses just want to know that you care about what they think.
Linda, we're seeing that with some of our survey work too, that being valued, being part of a team, connecting, and are huge. So yeah.
And I'll just add, it's maybe counterintuitive. Our nurses feel so overwhelmed, tapped out, drained, that they don't have time for one more thing. But yet, what we try to do is have them think about when they come to school for additional education, that's a place just for them. That's an investment. That is something that's filling their bucket, and try to frame it. And that's part of our responsiveness, to make it flexible, to make it, meet their needs, but to see that as an investment, and in a way that continues to, advance their education. Now, of course, I don't want to say we're adding to the statistics of the nurses who are leaving the bedside and becoming nurse practitioners, but if you see that as an investment of a resource of another type in the organization, and we have actually seen that, where nurses will say, I'm so glad, I'm coming to class, and I'm glad this is, I have really great conversation. I really have some peer support, and it really has helped me see that I'm investing in my own professional growth. And I think that's really important. So.
Absolutely.
So I'm looking on my screen and I see some things around Q&As and chat, but I'm afraid to touch any button because.
So this question says, what are your thoughts about the national move towards DNP as the exit degree for nurse practitioners rather than the master's or the MSN? How do you foresee the requirement of additional credit hours in nurse practitioner programs and interacting with nursing enrollment trends? So
wow.
Lydia, you are Peter.
Lydia, would you like to take that?
I will defer to you, Professor. And,
oh boy.
Well, I guess Linda and I will each have our thoughts about that, but I would really, appreciate your insights around that.
I think I'm trying to stay focused on what is good for society that we're producing in nursing. And early on, I had my concerns about the DNP, but as I've watched the programs grow and develop and have interacted with many of the graduates and people, I've become much more confident and supportive that they are the answers to a lot of our needs because of their management and their policy focus and other aspects. We need to ensure that they can provide that in the organizations that hire them and in other avenues. I think it's still an untapped potential. The politics of sort of DNPs and the levels, I stay away from that because I don't understand that well. But I would hope that whatever we do, we are thinking about, will this help solve important healthcare needs of society? And I don't really care what form it takes, but as long as we're directed there, that would be my answer. And Lydia, you can now really clean that up.
No, I think that's a really great framing of it. I think, you know, if you consider, there's a really great diagram I love. It's a classic iceberg model, and it has above the water is a purple, you know, the ice cap that says, you know, clinical care, clinical appointment. And a set that represents the interaction of a patient and a provider or a client in a healthcare environment. And then below the water, all these other things, 80% is below the water and has all the areas that we who have DNP education are very familiar with: quality and safety, policy, interprofessional partnerships, healthcare economics, systems-based practice, all this element. And the question poses is that these are the underappreciated influences of health, which we know very well. COVID has made that very explicit. So it's encouraging us to think of not of digging deeper, not to just think about what we treat above the water. And so the way I look at the DNP, and I'm obviously a huge champion, is that it is equipping our graduates to really treat the entire iceberg. Now, the mechanism of how we get there with all the logistics that people are taught, and they're significant, you know, the cost burden, the pipeline shortage, that all of that is certainly worth wrestling. But I think if we consider that all of that is important, and I would say that all those elements are codified by our AAC and Essentials, they're codified in NOB and TF guidelines. You know, if we know that those are relevant, then it shouldn't be, to me, the question is not should we, but how? How do we get there in a way that takes all these stakeholder perspectives, of which I would value Linda's as a CNO who says, who am I going to pay a DNP more? You know, the very real cost issues, the very real utilization issues. I'll just say one thing we've done to try to address that utilization piece is our CNO, and we've entered a DNP practice partnership where we have practice fellows who work at, with the medical center, and they come to school, we support their education, and then they work on practice priorities that then contribute directly back. And then we set them up for that model. So that's one small example, but and I know we only have a minute left, so I certainly want to hear Linda's perspective before we wrap up. But thank you for giving me the opportunity to weigh in.
I know. So I'm happy to hear, Lydia, that you guys have begun with that model. I'm going to call you because I would love to hear how it's going, because we were talking about this same thing as we were brainstorming with our School of Nursing here in Memphis. And so I'm a DNP. I'm all about it. I'm supportive of it. And as a matter of fact, a lot of our leaders are going back to school to get that. And this organization is, we're going to pay for it. And so it's just investing in what you have, because if you invest in those that you have, then you can do more and get more creative with your models of care. So I don't see that, you know, as a hindrance here, even though the bedside nurse is our highest priority. How can we, you know, put nurses at the bedside? But we do have DNP nurses who are paid higher who are at the bedside, but they're changing practice there in their local unit. So, there is value in DNP nurses here in the organization and the organizations at large. So I just think that is, I do want to touch, because I don't think I completely asked, as I know we're a little bit over, but I do want to touch about the driving factors for these young nurses is the acuity and is the patient nurse ratio. That's a big deal, because we've had to, with this great resignation, stretch our ratios, but we have not stretched them too far not to be safe. But that is a driving factor, because a lot of them, have the idea that I will come on board and I will have, the ratios will be very low. And once they get here, so that is a driving factor as well. And I just wanted to mention that.
Thank you. Well, I can't believe it. We're out of time. I thought we would have more time, but it went very quickly. So thank you so much, Dr. Bearhouse, for your time today. And of course, to Dean Jeffries for hosting this event.
Thank you.
Thank you. And I like this. This was fun. And I feel like we should do this a lot more, talking with each other like this. So thank you to Dean Jeffries as well, and to Sarah for helping put all this together.
Absolutely.
Absolutely.
Thank you.